to accept. So thank you very much for inviting me, and thank you to everybody that's attending today. Just it's typical for us to give some disclosures. I've had some research funding over the years from Heart and Stroke Foundation, CIHR, the St. Bona's Hospital Foundation, and the University of Manitoba, which have supported my work. Now, the things I'm going to talk about today are actually freely available on the internet. You can look up some women's heart health initiatives across the country in both Canada and the US. Or you can look up some free online papers, scientific papers that are available on PubMed and a few other databases like that. And the reason I picked these resources today is because I think that the infographics and the information that they share are really good education sources. And I wanted to make sure that I'm pointing people towards excellent education sources. There's a few slides in here of data from our own group that's published in different forms and things like that. If the slides look cool, I probably borrowed them from somewhere on the internet. I put the references down at the bottom. So you'll see here down on the very bottom of this slide is a reference. And I do that consistently throughout so you can see where the source is. And if the Reh-Fit Center wants a copy of the slides today, I can make sure they get a copy and they can be shared because these are public materials that you can download somewhere. So with that, I just want to make sure we're all on the same page with what cardiovascular disease is. Typically, we think about issues that affect the vasculature or the heart, and the brain's also involved. When we think of stroke or transient ischemic attacks, that would be a type of vascular issue that would be classified in cardiovascular disease. A lot of times I'm going to use words like heart disease, heart failure, stroke at other times. But I'm really, when I talk about cardiovascular disease generally, I'm talking about all the cluster of diseases, including peripheral artery disease, which isn't necessarily a heart or a brain issue, but it is a vascular issue. So if you have an interest in peripheral artery disease, stroke, heart disease, those things are all classified under cardiovascular disease generally. So the first thing I want to do is I want us to imagine a person that's having a heart attack, and I want you to think about what they look like. Okay, with that, a lot of people would think of an older male, somebody that might be a type A personality, maybe even that Hollywood type heart attack where somebody grabs their chest and they're like saying they have the big one. And that is one kind of heart attack. But the reality is that the face of heart disease has changed a lot in the last 30 years. Instead of just being 40 to 50-year-old men that are shoveling snow or maybe working high-stress jobs, we see a lot more women, and a lot more women of diverse backgrounds having heart disease. And back in 2018, the Heart and Stroke Foundation of Canada released this report called Misunderstood, and this is the cover page from it. And in that, they really identified a few really interesting facts that I think some people knew, but society broadly didn't really have a good understanding of this. And the research world really was called to action with this because the bluntness of the fact that we typically think of heart disease as a man's disease was really put out there. So heart attacks are actually more deadly for women. So men at 40 to 50 tend to have more heart attacks, but when women do have heart attacks, they tend to die more often. There's a variety of reasons for that, and we'll talk about a few today. We also know that women are 50% less likely to participate in cardiac rehab, and this is an indication that there might be some system issues. Why aren't our programs better at recruiting women into them from across the country, really? If we look at our statistics across the country, only 30 to 40% of people referred to cardiac rehab go, and it tends to be mostly a male-dominated participation rate. So we need to do better there, and that's across the whole country. Women are 5 times more likely to die from heart disease than breast cancer. But if you go in the general public and you ask what the #1 killer of women is, breast cancer is a big fear. And a lot of this is because of media-driven ad campaigns and such. But the reality is that far more women die of heart disease than of breast cancer. And then what we know is that quite sadly is that a majority of women that have heart attack or maybe early symptoms of disease before they actually have the heart attack, many of those women are missed. The early signs of heart attacks are missed in 78% of women, and this is quite startling. And a big reason behind it is that we think of the traditional way, that image that we had in our mind when I asked you that first question about imagine somebody having a heart attack. We think of like symptoms in a certain way, and we don't. historically clinicians haven't realized that women articulate their symptoms differently. They experience their symptoms differently. They have different symptoms. So those are three different things that we just didn't really have a good understanding of before. We've known for a long time that heart disease tends to affect men and women at slightly different rates. Stroke affects women more often than men, but they're both kind of here. And you see some statistics as women age. So these bars in red are all women statistics. As women age, 35, 45, 55, 75, 85 plus, heart disease deaths go up. And we also see that amongst all deaths and such here too. So these statistics are quite starting. So almost 35,000 women a year die of cardiovascular disease. Now, when men and women experience their heart attacks differs. So males are in this light gray line where my pointer is kind of going, and they tend to have heart attacks a little bit earlier, 40, 50, you'll see these rates higher. Women tend to be protected for a variety of different reasons that we don't fully understand, but some of it's because of an estrogen effect because they're female. And you see that women's rates really start taking off a little bit later in life, and they go up. And if you look at the same data and stroke percentages, you see males tend to get the strokes earlier, but women catch up quite quickly as they age a little bit more. So women tend to have a lot of heart attacks and stroke, but the onset happens to be later. So when we think of our friends, many of us think, well, I know way more men that have heart attacks that are my age than in other words. Well, they do, because men tend to develop the heart attacks earlier in life. So we're aware of it. But then as we all age, our rates go up at similar kind of rates, really exponentially. And this is Manitoba specific data. We actually pulled this from health records in Manitoba, and the paper was published by Randy Francouz's group at Manitoba Center for Health Policy. So this is really cool that we have this Manitoba sex-specific cardiovascular disease data. So this is a quote from Heart and Stroke Foundation from that misunderstood report. Are women's hearts really that different than men, is insinuated there? And this Dr. Humphrey says yes and no. And I totally agree. Based on the literature I've seen, there are some similarities between men's and women's hearts, but there's a lot of differences, even at the molecular level. So the proteins that women have tend to react a little bit differently to the proteins that are in some of the men's hearts or in the vasculature. And even though our drugs work well in women, they tend to work better in men because at the molecular level, the mechanisms are understood a little bit better, because historically, 2/3 of cardiovascular research has been done on men. That bias was something I think was done accidentally, but it's a bias nonetheless, and it's something that the Heart and Stroke Foundation and the Canadian Institute of Health Research are really advocating for researchers to look at heart disease in women specifically, so we can better understand the mechanisms at the molecular level in the body to be able to create better treatments to improve the outcomes for women. Because if you remember, women die more often from heart attacks than men do because we don't have the best tools to be able to treat them right now. So I want to come back to that question about, imagine a person having a heart attack. What image comes to mind? Many of us might think of that Hollywood type heart attack where it's the big one and they fall right over. Well, the reality is there's a lot of symptoms of heart attacks. Chest discomfort, pressure. Women tend to describe the chest pain that they have, not really as pain per se, but as pressure or discomfort, and maybe just feeling different. They use the vocabulary that women use is quite significantly different than men. Women talk differently than men and use different language. And because of that, when they describe their symptoms, they tend to use words of pressure and such, whereas men would use pain. Men would think of a pain in the one side of their body. Well, women might actually feel that pain a little bit more spread out. Sweating is a symptom. Upper body discomfort, particularly in the neck, jaw, shoulder, arms, or back. I'll show you a heat map in a minute about where women describe their pain. But some of the other symptoms that are on this slide are nausea, shortness of breath, lightheadedness. And on this diagram, the Heart and Stroke Foundation put this here. It's really important. Call 911 right away. A lot of times when women experience these symptoms, they either don't recognize that it's a heart attack or they don't think it's a big deal, so they don't take action. It's important that if you're having these symptoms that you realize that it might be a heart attack, and your best scenario would be is if you seek help. At least tell a loved one how you're feeling. ideally, if you're having symptoms like this, call 911 right away, because in Manitoba, our EMTs, like the ambulance drivers, when they come, they can actually give you medicines now to change, like a blood thinner, to be able to prevent clotting and such. And this is really cool. The other things that EMTs do in Manitoba that's really cool is that they'll take an ECG tracing, your heart rate tracing, and they'll be able to send that wirelessly to the hospital, where a cardiologist can look at it before you're actually at the hospital, and then that can inform care. So getting early care by calling 911 and treating these symptoms as serious is a really important thing that more women need to do, and more families need to do, to take care of their moms and sisters and daughters and such. Okay, so women tend to have symptoms more often when resting, or even when asleep, than do men. Okay, this is interesting, right? Like, you might be moving around the house or moving around doing some fun activity, but it's actually when you go and you sit down and you rest, or even in the evening when you're sleeping, that there's symptoms. And women tend to experience this more often, and a lot of people are just unaware of that. So if you're having these symptoms when you're at rest, or when you're asleep and you wake up and you have these pains, make sure you tell someone. Take some steps. Emotional stress is something that also seems to trigger heart attacks in women more often than it does in men. So being aware of that is an important thing for us to think about. And it's also important to know that heart attacks don't necessarily knock you on your butt, right? You don't necessarily fall over from a heart attack a lot of times. And this quote that was in this heart and stroke report: women need to know that they can have a heart attack, yet continue to walk, talk, and work. Okay, and part of this is because the type of cardiovascular issue that's actually happening. A lot of times in women, the changes in the vasculature aren't blockages, like 90% blockages of major arteries. A lot of times the blockages that are happening are in small arteries in the heart. So in the microvasculature, rather than the big veins and arteries in the hearts. So that's something to think about. Now, this diagram here shows kind of where an angina pain might feel. So the gray part that's highlighted shows where women might experience or articulate where they're feeling the pain in the neck, through both limbs as a pressure. Could be central in the chest here, maybe in the throat or lower jaw. And a lot of times it's in both arms, as opposed to just one arm strongly that we sometimes see in other individuals. Now, there are a number of things that might cause chest pain. Sometimes it's just some other health condition, some lung problems, sometimes gastrointestinal problems. And this one here is actually, these examples are some things that sometimes when women have heart attacks, they think, oh, I'm just having indigestion right now. Well, I would encourage you to actually lean the other way. If you're going to err on the side, you'd rather go talk to a doctor about, I have chest pain. I'm scared that it might be a heart attack. Can you help me? And then later on find out it was just intestinal issues. Because in that situation, you're more likely to survive if you go see a doctor early. Okay, so that's an important thing. And I'm going to keep talking about being an advocate for yourself, looking out for your own health, and talking to your physicians and primary care providers, nurses, and such about this. So there's some language that's really bad in medicine. Things like atypical and typical angina. So typical angina would be the way that men would describe it, and the way that clinicians would look for it. The clinician would listen to what you're saying and look for certain words. And then anything that didn't fit that typical angina description, they historically would classify as atypical. Well, in the last 5 years, we've realized that language is actually biased as well, and we're starting to try to change the language that's used. We realize that there's angina, and then there's a different way of describing angina, and we have to be much more open to hearing what the patients are telling us. So things like vague chest discomfort might be atypical angina, and then some other kind of things that are listed here that were on the previous slide might be more of the typical part. But that atypical typical isn't really a good description anymore. We're trying to change clinicians so they don't use that language. So sometimes the signs of a heart attack are mild or sometimes severe. A lot of times women would describe their angina pain as maybe being atypical. They probably wouldn't use that word, but that's what a clinician might pick up. But like I said, we're trying to change the language being used, because a way a woman experiences a heart attack isn't atypical. It's the way that a woman feels a heart attack. They describe it based on their experience and their vocabulary that is more typical for women to use than it is for men. So we're trying to change this. And some of the factors that influence women's heart disease are things like hormones, diabetes, and a few other factors. Um, and again, I want to emphasize, if you have symptoms, it's better to take action and be safe than it is to be sorry and not take any action at all. Okay, so I alluded to the fact that women's heart disease tends to appear in the smaller blood vessels of the heart, in the microvasculature, more often than it does in the major coronary arteries. So when we think of men's heart disease in that big Hollywood heart attack, that tends to be when there's 90% occlusion of a vein of an artery in the heart or more, and then somebody just falls over and dies, right? Well, women tend not to get that because it's their microvasculature that seems to get clogged up with cholesterol and plaques and such more often. A lot of times there's some different tests that are used by physicians and the healthcare team. Angiograms and stress tests can be used, but both of these are actually less effective in women than men. Now, they are effective. It's just their sensitivity is a little bit lower in females than it is males. And that's probably because historically the cut points that we use for some of this work is for some of the diagnostic tests was predominantly created in men rather than women. But as research is moving forward, we're trying to get better, more sensitive tools and make the existing angiograms and stress tests better at detecting women's heart disease. And then sadly, a lot of times women that do experience cardiovascular disease risk factors or adverse events, a lot of times they're actually less likely to be prescribed the medications that we know will influence blood pressure or cholesterol lowering following the heart attack. And this is kind of sad. So there's a few things, I have a few slides to talk about this to be able to explain how you can advocate for yourself. And then women, of course, women are wonderful things. We all have a mom. And we have to think about the life cycle of women and how their life actually might impact their cardiovascular risk. So we've now learned that a fetus, when it's in the womb, is exposed to its mother's kind of metabolic conditions and what its mother's lifestyle is. And we know that cardiovascular disease risk starts as early as in the womb. And then as people develop into children and women and so on, things like pregnancy, menopause, and hormonal changes through menopause can actually have major impact on future cardiovascular disease risk for women. And this is something that we have an understanding of partially, but there's a need for a lot more research in this area. And a lot has started going on in the last decade for sure. So women aren't just females or females' sex. Women also have a lot of roles that are socially constructed, and the term that we tend to use for that would be gender. So when we think about sex and gender, a lot of times we loosely use those terms, and scientists are horrible at this. In my group, I have a couple students that remind me all the time when I say male or female, I'm talking about biological sex. And when I use the word woman and man, or the other varieties of self-identified terminologies used for gender, because really we need to stop thinking about gender as binary, and we need to realize that gender really is a social construct that has a continuum. Okay, and I'm going to show you a slide on why thinking about gender as a social construct is a really important kind of thing. We all know that women historically have typically taken care of others a lot more often than men have. There's very traditional roles. It's interesting when I'm only 43 years old, but when I talk to my students that are 20, their perspective on what roles men and women have in the household are incredibly different than mine. And they're only 20 years younger than me. And then when I talk to my mom and dad, who are from a really much more traditional kind of background than many are now, it's quite interesting that my perspective on roles in the household or work is totally different than my mom and dad's, even though my mom was a full-time teacher and she worked her entire life since I was born. But over time, these concepts change. And the reason this is kind of important is women are female and biologically different than men, but those roles, those social roles that they have also have significant impact. So this is a really foundational, seminal type research project that was out there. And what this group did, they looked at acute coronary syndrome or they looked at outcomes after somebody had a heart attack. And what they did is they decided to look at both sex, so male or female at birth, so biological sex, and they also looked at gender on a scale. Now, it's difficult to come up with a really good way to measure gender because the tools don't really exist well yet. Stats Canada, as an example, has been developing a tool on gender to use. A lot of times we use open-ended questions to allow people to self-identify, which is the right way to do it. Another way that's been used in this study is they created a chart where they looked at masculine characteristics to scale across to feminine characteristics. And if you look at men, the men that answered this survey fell somewhere between 0 to 100. So it wasn't about being male at birth. It was more about what their gender role was in society and in their household and such like that. So they scored between 0 to 1, and that's the red line. And then the women that were in the study, so females at birth that were in the study, when they reported this, you see their scores are different. And then many of them reported having totally 100% feminine characteristics, and some of them reported having masculine characteristics and everything in between. So what you see here is you see a scale of gender. Is a good way to say this. It's not the perfect measure, but just stick with me that this is an interesting thing, and I'll show you why. So what they see here is that if you look at this group here, this is looking at males and females only. Okay, so biological sex, and somebody that's male or female, their outcomes after having a heart attack were somewhat similar. There's about a 3% incidence rate after this. Okay, but you see that men and women, or male and female, is actually the proper term to use here because we're looking at biological sex in this part of the graph. Their outcomes were similar. But if you looked at gender instead, so the roles that people had based on the scale, you see that people that showed more masculine characteristics had better outcomes than the people that were showing more feminine characteristics. Now, I acknowledge this isn't a perfect measure of gender. It's a really clumsy way. My students that are 20 years old tell me they don't like this tool. But this is what was used in the literature and published just a couple of years ago. And it's really interesting. People that have more of a feminine role in the household have worse outcomes than people that have more masculine characteristics, and that's regardless of sex. So it shows us that women, because women are both female and have gendered roles of some type, when you look at this, it's much more complex than women are just not men. It's actually, there's things here where it's both biology as well as roles that we have in society. So the social construct of being a woman actually contributes partially to the fact that women have worse cardiovascular outcomes. So when we think about heart disease, we have to think about both the biology of it as well as the social roles that we have women doing in society. That's important. Now, Heart and Stroke Foundation released this in their report, that misunderstood report. Only 20% of women's doctors actually talk to the women about their heart health on a regular basis. Wow, like I know in my age, every time I see my doctor, he asks me about my cardiovascular health and other risk factors. So I was shocked when I saw this. Only 1 in 5 women, their doctors talk to them about heart health regularly when they see them. So I looked at a study, and I found this one in Ontario. So this is a study looking at the Canadian Cardiovascular Harmonization of National Guidelines Endeavor. So they call it C-Change. And they wanted to figure out, is this problem with only 1 in 5 women being talked to about their heart health by doctors, is it being influenced by patients or is it being influenced by clinicians? And the take-home message that they found is that the majority of variations in adherence to these cardiovascular guidelines were attributed to patient attributes, but a substantial proportion of unexplained variation was due to differences among physicians and the clinics. Okay, so said differently, the patients need to take a more advocate role to talk to their doctors about their cardiovascular health. The clinicians, the physicians, nurse, as well as the clinic staff themselves, the way that the clinic is structured, they also need to talk to patients more and actually make sure they come up with systems that better support women in their cardiovascular health. So it's a little bit of both. So how do you advocate for your own health? How can women talk to their physicians about this? Well, The Canadian Women's Heart Health Center at the Auto Heart Institute has this awesome website. Here's a link, and if you just Google this site, you'll find it. And they, under their tools and resources, they have something about talking with your health provider. And they actually give you a list of questions. So these ones are under the tab General Questions. So you should ask your doctor, what is my risk for heart disease given my personal risk factors? Are tests needed at this time to check my risk of heart disease? If so, what are these tests? How often should these tests be done? Okay, I'll give you an example. We're doing a research study right now where we've had 350 women come in, and we've had women come in and tell us they're feeling fine, and we've measured their blood pressure, and they're walking around with blood pressure of 180 over 90. Now, 180 over 90 is a very, very high level of hypertension. So a lot of times we ask them, when have you had your blood pressure checked last? And many of the women that are in that situation have told us they haven't had it checked in the last year. Okay, that's startling because normal blood pressure is 120 over 80. So if you're at 180, you're way past what a hypertensive level is. Okay. We've also had other women come in and we measure their blood pressure and they might be at 160 or something. And we say, are you aware you have high blood pressure? And they'd say, yes, I am. I'm on medicine for that. And we'd say, well, when was the last time you saw your physician? And they'd say, well, about 3 years ago. Okay. So what happened is they probably had high blood pressure. They saw their physician and they're given medicines. But over that 3-year period, they stopped seeing their physician. They stopped having their blood pressure checked. They became unaware that their medicine probably wasn't at a dose strong enough to be able to give them protection anymore. So they stopped having a regular test. And that was actually causing them harm. So what we did is we recommended they go back and see their healthcare provider and they seek medical advice from that provider. And a lot of times when we do that, the women send us an email back saying, thank you for telling me this. My doctor has changed my prescription. I'm on a different dose now. So that awareness of having tests done on a regular basis empowers somebody to advocate for their own health. So that's a really good question. And there's a few other ones here. I'll highlight this one. Are there any lifestyle changes that'll help me to lower my risk of heart disease? Should I be taking medications? Okay. Now, these are the questions under the general questions. There's also a number of things that are listed under subtitles here: diabetes, smoking, high blood pressure, cholesterol, and so on. Heart disease across a woman's lifespan. Okay. Those are at the same level of this general questions highlight. That's why I put them all in that red burgundy color. And they all have a subset of questions. So if you're interested in better advocating for your own cardiovascular health, this site actually has some really nice questions you can ask your care provider next time you see them. It won't take long to go through, but probably important for you to do if you want to advocate as strongly for your health as you can. Now, here's an infographic from that same Canadian Women's Heart Health Center. It talks about heart disease across the lifespan. There's risk factors for women when they're adolescents. So having early onset of menarche can cause increased cardiovascular disease risk. When you're a young adult, you can end up having impacts. Pregnancy can lead to some impacts, and also postmenopausal. And you have to think about cardiovascular disease over the entire life cycle, okay? Because it doesn't just happen. You don't just have a heart attack. Things that you did yesterday and last year and when you were younger have an impact. So here's a really neat research study. And what I want you to know is that here's a list of a variety of things that are related to reproductive health of women. Okay. And then there's this line that goes down the middle here, a composite cardiovascular disease score. And that line represents 1. So anything to the right of this line is elevated cardiovascular disease risk. So let's just grab some. So if you have moderate preeclampsia, you're actually at this dot here in line is far right of that risk factor line. And this is telling us that you're actually at a 242% increased risk of having a cardiovascular disease issue later in life, just because you had moderate preeclampsia earlier in life. And there's a number of things that are on this graph. They're related. So preterm births have a big impact. If you have placental abruption, has an impact, and some other kind of things. And this study actually was really cool because it was a review of 32 papers, and they had thousands of participants in it, and they look at 7 to 10 years follow-up from many of these things. So this is really profound evidence showing that the lifetime things that women go through that men don't partially explain why women have poor health outcomes after a heart attack. So another thing that's related to life cycle or lifetime, menopause. So if we do a similar kind of systematic review and we look at this again, what you need to know here is that there's a line, and if this diamond is the right line, you have increased risk. So if you have early onset menopause, so if you experience menopause before 45 years of age, you have elevated cardiovascular disease risk, and you should be talking to your physician about just checking your other risk factors. If you had menopause after 45, your risk profile goes down quite a bit. So age of onset of menopause is a risk factor that people should be aware of. Talk to your doctor about it if you experienced early menopause. Um, there's over the years, there's been a lot of research looking at hormone replacement therapy. Is it good? Is it bad? Um, we're starting to now understand that some of the trials that say it's good or it's bad might be explained by differences at the molecular level. So the way that physiology is actually happening. But when you look at all the studies together and you look at 19 trials with over 40,000 women, it seems that hormone replacement therapy has no effect on cardiovascular disease. Now, this might be because in some people it's good and other people it's bad. And the most recent literature might be, or is starting to tell us it might be that age of onset of menopause that might be influencing why some people respond well to hormone replacement therapy and maybe why others don't. And so we don't really fully know yet, but right now the literature is saying that hormone replacement therapy has little impact on heart attacks or cardiovascular caused death. Now, there is a small risk, a small elevated risk of stroke or some types of blood clots in veins that can happen. So if you are or have ever had hormone replacement therapy, you should talk to your doctor about are you at elevated risk or is there any concerns there? Because the physicians will know much better than I do how to advise you well. Okay, so the good news is that even though there's a lot of things that can influence cardiovascular disease risk in women through their life cycle, up to 80% of premature heart disease and stroke is preventable. And this has been shown in trials that have included over hundreds of thousands of people. A McMaster group showed this. Is really cool. And there's some things that we can't change. We're all getting older. We all have the genetics that we were born with, and we all come from an ethnic background that may have certain elevated risk or not. But there's things that we can modify, including things like stress, activity, alcohol intake, smoking, blood pressure. We can manage our diabetes or pre-diabetes if we can, and we watch our diet. So there's things like move more, sit less. And I know that there's been some speakers in this Reh-Fit series that have talked about that. There's eat heart healthy meals. So omega-3 fatty acids is an example. Eat lots of fruits and vegetables, because if you eat those, it's raw materials for our body and not processed in a machine that breaks down the actual nutrients. Stop smoking. Even if you smoke today, if you stop, your risk will go down. Take your medications as prescribed. 30% of people take their medication properly. 70% don't. So if I give you a pill and say this will make you live longer, 70% of people don't do that right. Don't take their medication properly. Please do that properly for us, okay? Because it'll help you. And then know your numbers about things, blood pressure, cholesterol, and if you're diabetic, then your A1C, which is a measure of your blood glucose over the last 3 months. So know those values, because here's a body mass index. If you're obese, your risk goes up sevenfold or fourfold relative risk here if your body mass index is big. If you have high triglyceride levels, your risk goes up significantly by 2.5 times. And that's it's actually higher in women, the light bars versus the dark gray bars were men. So cholesterol and triglycerides affect women disproportionately more than they affect men. And we know cholesterol in men are bad. My wife bugs me all the time about my cholesterol, and I'm glad to say that somehow genetically I'm just lucky to have good cholesterol, but I also carry a lot of body weight, so that's not good. Thankfully I'm a male, and those things affect me a little bit less than women. And we have to be aware that these are some sex differences based on some of these risks. If we look at the tools out there, if you want to lower your cholesterol and improve your heart health, reduce cholesterol, the bad cholesterol, LDL. Here's the image. Bad cholesterol's LDL, good cholesterol's HDL. You want to eat lots more good fruits and vegetables. You want to reduce certain carbohydrates, simple sugars, things like that. Okay, there's ways to do it. We also want to move more. So we know that hypertension affects women more often than men. We know that diabetes actually is worse in women than men and contributes to cardiovascular disease worse in females than men. But activity, the lack of physical activity is actually more detrimental in Manitoba and females than it is in the males. So females are in yellow here and males are in red and black. Okay, so just recently, about a month ago, the federal government and the Canadian Society for Exercise Physiology released new 24-hour movement guidelines. They want you to move more, they want you to sleep well, and they want you to reduce how much time you're sitting in front of a screen. So you can watch this for the rest of the time I'm talking and ask questions, but after that, I want you to go move a while, okay? And we need to think about the 24-hour period, because if you move more and you watch less TV and computers, and then you get your good 7 to 9 hours of sleep, you're going to be most healthy. And the reason this is because you become less frail. We have to think about cardiovascular disease and diabetes and a lot of cancers and stuff actually being caused because our bodies want to move. So disease is actually caused by loss of muscle mass, the loss of aerobic fitness, things like that. We might see them actually really early as we age. We know people that are really fit and able to move fast. We also know some older people that walk slow. Sadly, we know some 20-year-olds that walk really slowly and tend to be obese and tend to be sick as well, right? So a lot of times walking speed is a really good measurement of this concept of frailty that leads to poor health outcomes. So you want to move, you want to have more energy expenditure happening to challenge your body to burn that energy that it wants to make, burn fat, burn sugar, right? You want to eat well to be able to give yourself the good nutrition from fruits and vegetables. Get enough protein in your meals from any source, if it's through vegetables, if it's through milk or dairy, or if it's through meat, that's great. But make sure you're eating well, moving more. You'll actually counteract this physiology of frailty. So the reason this is important, this was a trial that my group did here at St. Boniface Hospital. We had over 1,000 women come into the study. The key part here is that as people become more frail, and this is overtly frail, the frail group had 2.81 times higher risk cardiovascular disease than people that were not frail, the reference group here in gray. So think about that. If you can walk fast, if you can do 30 minutes of exercise every day, and if you don't feel tired, your chances of heart disease are a lot lower than if you can't do those things. So moving matters. Okay, and what we know is that physical activity is a great way to counteract frailty. If you can move and lift small weights, you don't have to be like Arnold Schwarzenegger, lift big weights, but if you move and you lift small weights, that's better. If you're able to lift big weights, great, do that. But you just need to keep moving, because we know that physical activity, resistance training, and right diet can be really effective at delaying the onset of frailty and cardiovascular disease. So this is a really neat public health message that was in Britain. And of course, it has to be British because of the whole image here, right? But get your physical activity any way you can is the take-home message here. Just move more. Okay, and the Refit Center is phenomenal. Now, they're not paying me to do this or anything like this, but I really like this idea, because at the St. Boniface Hospital, we've been talking about how we can better support people to be more active at home, especially since COVID hit. We're not able to meet with patients as often. We're not able to meet our clients as often. And the fact that the Reh-Fit Center is able to support people anywhere and has an app to be able to support people, that they're providing some online lessons and such, is phenomenal. This is cool. I want to show you, because this is one of my master's students that's working at the Reh-Fit. And the fact that they're integrating new approaches to support people to become more physically active is exceptional. So you should be really proud of being part of the Reh-Fit. If you'd prefer to get your knowledge about how to be HeartSmart or HeartSmart, the Heart and Stroke Foundation have this tool. The guide's available online. I just Googled it. And they talk about different things that you might want to know. You might want to know how to make lifestyle changes. You might want to know about signs and symptoms of heart disease in women. You might want to know about tests or medical management. It's all in this tool. So go look it up if you want to, or ask some questions. My group is, like I mentioned, we do some women's cardiovascular heart research. we're actually trying to develop new tools to better detect early cardiovascular disease risk in women, and we're currently recruiting for a study. It's called Warm Hearts. One of my students came up with this idea to be able to come up with a nice logo, and it's pretty good. So far, we've had 350 women in this study, and once the pandemic calms down, we're hoping to recruit another 650 women. So if you're interested, Google Warm Hearts and let us know you're interested. But on that note, I'll wrap up. I went a little bit longer than I wanted to, but I'm available to take a bunch of questions if people would like.
Thanks, Dr. Duhamel, Todd, for that presentation. It was a lot of really interesting information, and maybe as I'm a woman and getting older, I'm paying attention a little bit more than I used to, maybe in my 20s, but definitely some points that I'll probably bring to my doctor next time I see her. So thanks for that. Again, if anybody has any questions or anything, I know it's a little bit over, but if you want to put them in the chat box, Gord kind of gave us some prompting there. If anybody wants to chat, we'll maybe give it a couple of minutes. I have to say, Todd, I think one of the things that I recognize most, and this was probably 15 years ago, is close family member, female, obviously went in and they just kept telling her for over a year that it was arthritis that she was having. It was her ribs that were sore, and it wasn't her heart, even though she had an extensive heart history background and it was family related. And then it took a year for them to kind of push, and my pushing a little bit as well. So it's interesting. So hopefully that changes.
Yeah, my mom had an arrhythmia, and they kept saying, "Oh, it's just going away. It's no big deal." And I'm like, "Well, Mom, there's a few questions you need to go ask." And after she did, then she got a Holter monitor. But it took her a little while to advocate to be able to get one.
Yeah, it's that you definitely need that avocation. So some positive comments from some of our members. So that's nice to see.
Yeah, thanks, Aaron. I always try to make these interesting and not too geeky, because as a scientist, sometimes we talk too much about that. But I hope the tools that were shared here were useful. If you Google Women's Heart Health Canada, you'll be able to find a lot of these tools. Anything from Heart and Stroke Foundation, Ottawa Heart Institute, Refit Center, Wellness Institute are going to be evidence-informed tools. So I highly recommend those.
So there's one question there, Todd, from Jan. I don't know if you've got it. You can maybe answer it. You want me to read it out loud, or?
Jan, if you're referring to Happy Hearts, we did that a couple of years ago. We did look at arterial elasticity. If you were in that Happy Hearts study, yeah, you're not allowed to come into this one because we're actually pooling the two studies together. I'm really glad to hear that you were in that study. Thank you very much. We've published about 5 papers from that now, and we're actually coming up to the time point where we're able to look at the 5 years since participants came in. And we're really excited about the data that we're going to get, because we're going to be able to see if any of those artery elasticity measures we did actually worked. We're actually really excited by exercise blood pressure response measurement that we did in that too. So what we do is we measure blood pressure typically when somebody's sitting and at rest. But what we're finding, us and others that have published on this topic, that if you get somebody to exercise for 3 minutes after doing a couple stairs or doing maybe a treadmill at a light and moderate intensity, that response of blood pressure change, some people change a lot and other people change a little bit. And actually the people that were changing a lot, that's a measurement of artery stiffness. And it's really interesting, because if you have stiff arteries, your blood pressure jumps a lot disproportionately compared to what we'd expect. So it's a really interesting measure, and we're curious about that measure because we can do that anywhere in Manitoba. Any clinic, anywhere in the province, we could do that exercise test. Just measure blood pressure before and after 3 minutes of exercise. So that's one of the ones that we are really interested. So I'm really glad that you mentioned you're in that Happy Hearts, because as you can tell, I get excited about it.
There's one more question here from Aaron. Are the factors that exclude women from the Happy Heart study the same for the Warm Heart study?
Yeah, they are. So what we're looking for is women that are 55 years and older, that have never had a heart attack or stroke, And if you contact us, we have a little phone script. We'll call you. We'll ask you a few questions, and we can better screen it that way. Um, so just Google Warm Hearts, University of Manitoba, or Warm Hearts Todd Duhamel, and you'll find it. Or if you're a Refit member, Rhea knows how to get a hold of me, and I'm sure she could share some information with you.
Yeah.
But basically, we're looking for women 55 and older that have never had a heart attack or stroke before. And then there's a couple other questions, but we'll ask and we'll tell you what the study's about. So you're well aware what we're asking and how many hours it'll be.
Great.
I was trick or treating with my kids, not this year, but last year. And we went to a house, and a lady answered the door, and she's like, Dr. Duhamel. I said, yes. She's like, I was in your research study. I'm like, really? That's awesome. I said, which one? And she's like, Happy Hearts. I'm like, phenomenal. She just recognized me. So it's kind of cool. But it's so great when we can meet the people that are in the research, because the reason we're doing this in Manitoba is we want to find some tools that are going to work well in Manitoba. And what we found is just like Jan's saying here, a lot of the women that do the study tell their friends about it. So we actually have one group from St. Anne's, Manitoba. One woman started and got 64 of her friends involved.
Oh, 64.
Yeah.
I don't know if I have 64 friends. Wow.
Yeah,
That's
it
amazing.
got onto a walking group or a Facebook group or something like that, and it was awesome. So like it's nice that we've had good reception from the community and people have helped us recruit. This pandemic's been really hard on our project because we've had to pause for 6 months and then we restarted, and then we had to pause again when we went to Code Red, which I know is the right thing to do given the current context of Code Red and COVID and everything. But it's just really hard because we're excited to do the research and we have to wait.
Well,
So hopefully COVID's gone.
we have lots of 55 plus women, so we will do our best to get you some recruits, Todd.
Cool.
So I don't see any other kind of questions popping up again. Some thanks again for the presentation. And again, I would echo that as well. It was a really great presentation, and thanks for your time tonight. I'm going to say goodnight to everybody else that joined us, and we don't have any more talks until the new year, and we're still kind of waiting on the schedule for that, but we appreciate you participating with us, and again, appreciate Dr. Duhamel to leading this presentation. So have a good evening, everybody, and we will chat with you soon.
Thanks for coming.
Thanks. See you, Todd.